This is Dr. Bishai from the Harford County Health Department, and I'd like to share with you some of the evidence about measures that can help keep schools open based on publications that were published in the peer-reviewed literature over the last 18 months. I'd like to answer 3 questions tonight, and the questions will be: how big of a threat is COVID to children in America? Second, are masks safe to use as part of a layered approach to keeping schools safe? And what is the evidence that wearing face masks will be effective at keeping children safe? So I'd like to begin first by reviewing the size of the threat to U.S. children from COVID-19. Since the pandemic started, there have been 400 pediatric deaths that would fill a jumbo jet. Imagine if we went back to 2 or 3 years ago and we heard that there was a jumbo jet full of 400 children that might face mortal danger. I think a lot of us would be very concerned that this was a very serious problem, and we would ask, what could I do to help prevent this tragedy? That tragedy looms before us because not all children can get vaccinated, and with the Delta variant arising, as I'll show soon, we are not out of the woods on this. Since the pandemic started, there have been 209,264 pediatric hospitalizations and 4.1 million pediatric cases. The threat is rising again. This is data from the state of Maryland as of August 7th, 2021 on hospitalizations, and you'll see at the far right that hospitalizations in Maryland for children under 18 have begun to rise again because of the Delta variant. Furthermore, here in Harford County, the case rates are rising. The blue curve that you'll see the arrow pointing to is children between 0 and 19. They and adults between ages 20 and 39 are the leading patients that have developed COVID-19 in the last 3 weeks. I'd like to remind everybody that there are thousands of immunocompromised residents of the county. I looked at our databases to find 800 cancer patients that are being actively treated for cancer in Harford County. Many of them are getting chemotherapy that suppresses their immune system. Thousands more are on steroids, transplant drugs, drugs for arthritis that suppress immunity. These are people that even if they choose to be vaccinated, they cannot be sure that the vaccines will produce immunity. Because of this, they've now become eligible for booster shots. I hope people in this category reach out to their doctors, go down to the local pharmacy and get their booster shots. And even then, we're still not sure whether the booster shots will give them adequate immunity. So this group of county residents must rely on the rest of us to hold down transmission rates to keep them safe. We have evidence about school opening and in-person instruction. We were at this juncture a year ago in the fall of 2020. We entered an attempt to offer our students in-person instruction with multiple safety layers. This was attempted and then abandoned by early fall. Back then, we had no vaccines for staff or for any students. The virus back then was less infectious. We went to a masks optional policy in summer of 2021 here in Harford County and many other counties in Maryland as well. Here in Harford County, we've had 2 school-based outbreaks so far, one in a public and one in a private school. So that was the last time we attempted in-person instruction. And as I just showed you, pediatric hospitalizations are higher now than they were 12 months ago, and they're rising. So I'd like to turn to begin to answer the question about how dangerous it is to be a COVID-19 school contact. I'd like to introduce the case by showing you that COVID spreads from primary cases on the left who go to an area where they come in contact with other children or even with teachers. And then some of those contacts become secondary cases. For a lot of the next 10 minutes, I'd like to talk to you about how we measure how dangerous COVID-19 spread is. We use a word called the secondary attack rate. The secondary attack rate is how likely it is that any of these contacts on the left will lead to an infection on the right. The secondary attack rate is the number of secondary cases per contact. What I'd like to do is to give you evidence from the peer-reviewed literature on what these secondary attack rates are in schools without masks and what the secondary attack rates are in schools with masks. One of the best studies about the attack rate with masks comes from, turns out, Luxembourg. It comes from May of 2020. Luxembourg, like many places, and wanted to get their kids back to school. And they were doing that over a year ago. They kept requiring masks on school buses, but they did not require the masks in their classes. They did require 6 feet of social distancing, and they reduced class sizes. They canceled all sports, and then they began to offer PCR tests for everybody. This was at a time which was the ancestral strain of COVID, not the Delta variant. But it gives us a chance to see what would happen if a school did a policy like we ran here in the summer, where there was mostly reliance on social distancing and ventilation, but not on masks. In Luxembourg, last May of 2020, they found 179 primary cases in children that led to 49 secondary cases, and they could calculate a secondary attack rate. Overall, it was 27%, but they separately calculated as 20% in elementary schools and 38% in secondary schools. Those are high numbers, and that's happening with no vaccines and with no masks. So these are high rates of attack. In these elementary schools, you see that there was a lower secondary attack rate. So there's many other studies besides Luxembourg. Luxembourg is one of the best. I went to a summary study by Irfan et al. That was published in 2021, where they summarized 16 different examinations of the secondary attack rate in schools without masks. And without masks overall, we're finding a similar rate with ancestral COVID. The COVID of last year led to an 18.6% attack rate, meaning if an active case is in school and you're exposed to that child, you have about an 18.6% chance of getting COVID in 2020. Because the Delta variant is known to be 2 times more contagious, it's straightforward to estimate around 36 or 37% risk per unmasked contact with a Delta variant. Would like to share that number with a school district that is contemplating attempting to open in-person instruction, relying on layers of protection like ventilation and social distancing without the masks. The data that we have from last year and what we know about the Delta variant predicts that contacts will lead to a COVID infection almost a third or more of the time. That's what we know about how infectious the Delta variant is. Let's look at what we learned about attempts to open school with the use of masks. This study was published in March of 2021. It's by a group led by Professor Dawson. There, they studied 22 schools between December 7th and 18 and December 18th in 2020 in St. Louis County and the city of Springfield in Missouri. At that time, community incidence was about where ours is right now, with 51 to 71 cases per day. All of the schools in the study mandated face masks, distancing, ventilation, and they kept a quarantine rule. Dawson and his colleagues found 56 cases in all of the schools, and those cases were known to have had infectious type contact, high-risk contact with 270 individuals, mostly students. Well, compared to what we just saw with an unmasked school offering an 18.6% risk of a secondary infection, in the Dawson study with masks, there was a 2% secondary attack rate. That's a much lower rate of secondary spread than what we were used to with the no mask situation. Furthermore, schools were safer than the community. They found that the incidence in schools, instead of being at the community rate of 51 to 71, the incidence in schools was 0.57 per 100,000. That's 100 times lower than the community, showing that the schools with these policies were safer for a child than to be out and about doing whatever the community was doing with the susceptibility of the average member of the community, which children don't really have. Another study from a school with masks comes from Salt Lake City, Utah. And there were 20 schools, K through 6 only. These are elementary schools by and large. December of 2020 to January 31 of 2021. That is a pre-COVID, pre-Delta variant time. And there again, this is a community incidence rate very much like we have in Harford County today, with incidence between 41 to 96 cases per 100,000. They had a mask requirement in the schools in this school district, but they had investigators examine what the compliance was, and they found 86% were complying with masks, and school distancing was kept at 3 feet. The Hershow study from Salt Lake found that there were 51 cases. Those cases had a lot of contact. They had about 20 contacts each, leading to about 10,041 contacts. What's striking about the Hershow study is that with this universal masking policy, even with the 86% mask use, of those 1,041 contacts, only 5 got COVID from an in-school contact. So the secondary attack rate, not 18.6%, not 30%, but 0.4% in school-based contact. That's, again, a dramatic reduction in the secondary attack rate. I want to look now, going beyond the attack rates, to look at the general effect of COVID rates in schools with and without masks. A study of the incidence of COVID in Wood County, Wisconsin, where they were able to look at 17 schools from grades K through 12 in rural Wisconsin. The schools here required universal masking, and according to monitors, they were able to attain a 92% compliance with their rule that people should use masks. In Wood County, Wisconsin, the community rate was 5,466 per 100,000 cumulative over time, and there were 191 cases in students and staff in the school district, but only 7 of those cases were required in school. I want to show you what the epidemic curves looked like in Wood County. Here in the black, you see the general population's rate of COVID over time, starting in August with low rates of COVID and then building up over the fall. We kind of lived through a curve like this ourselves in Maryland last year, where the epidemic really rose up into November. But in their schools with the universal masking, the in-school rate is this low dotted line that's at the bottom of the curve. There were many other cases in school-age children in the dashed blue line above, and that dashed blue line was 37% lower than the community line. But the in-school spread with their masking policy showed that schools were, again, one of the safest places a child could be at this time, and the community spread in children was not as high as the general community, but much higher than what was happening in the schools. In Florida in 2020, from August to December, the entire state of Florida was submitting data about their COVID infections. And so the study involved 6,800 K through 12 schools across the state, hundreds and hundreds of thousands of children. In Florida, then, there was some schools that masked, and 40% wore masks as a school policy, but 60% of the Florida schools last fall did not require masking. And we can compare now the cumulative incidence of COVID was 1.7% in the schools that did not require masks, and 30% lower in the schools that required masks, showing that in the state of Florida, the masked schools had less COVID, less students going to quarantine, fewer outbreaks. In North Carolina, we can see COVID-19 rates in schools with masks. In 11 school districts, 90,000 students observed between August 15th, 2020 and October 23rd, 2020. High rates of mask adherence with the exceptions at meals. There were 773 COVID cases in the students in this school, but only 32 of those were cases that were acquired in the schools. And when they looked at how the cases were acquired, most of these 32 infections were when the child took off their mask. When the masks were on, the rate of infection was much lower. We learned a lot from these studies, especially the Missouri study, where they offered what we are thinking of offering around the country now, which is an exception to quarantine if the contact occurred while both were wearing masks. They saw in Springfield that there were 42 students that looked like they were in proximity to each other for 15 minutes, but both were wearing masks in schools with universal masking and social distancing and ventilation. 30 of those students agreed to be tested and none tested positive, giving us some confidence that exception to quarantine policies are safe. I wanted to talk about the safety of masks. Are masks safe for children? Now, the scientific literature on the safety of masks shows that they are associated with higher rates of skin irritation and acne. And there are individuals that have developed dermatitis and a flare-up of their acne when they wear masks for prolonged periods. So this has to be managed. There's been scientific study of the effect of wearing surgical masks, paper masks that they were worn in a medical setting, as well as single layer cloth masks, both during exercise and at rest. And they've studied both the oxygen levels in the blood as well as the carbon dioxide levels in the blood, both at rest and during exercise. And there's been no reduction in oxygen levels, and there's been no increase in carbon dioxide levels, refuting the claims that an ordinary mask makes one rebreathe their own exhaled air. That's not seeming to be happening. I would caution anybody who is wearing a mask or the school community that there are some vinyl masks, essentially putting a plastic film over the face and nose. Those have not been studied, but I would highly recommend that students be allowed or teachers be allowed to be wearing a vinyl or a plastic film over their mouth and nose, because that has not been studied, and because gas doesn't flow through plastic the way it flows through cloth and paper, those should be discouraged, and the school should use safer masks. There have been some studies on children's ability to recognize facial emotions. They showed children between ages 4 and 8 pictures of people's faces making facial expressions. They had one set of pictures covering the mouth and nose with a mask, and another set of pictures wearing dark sunglasses, and they asked the children to rate the facial expression. The children were able to understand the facial expression equally well whether the individual was wearing sunglasses or wearing a mask, and they did better than chance. The children did better when the face was uncovered by both either a mask or sunglasses. But children seem to look at the eyes as much as the mouth for emotional recognition. The time of developing the ability to say words and understand how to form a vowel or a consonant really is work that the child's development does in infancy between ages 6 months to 3 to 4 years. That work is generally complete by kindergarten. We already know that blind children have no delay in their ability to form excellent vowels and consonants, and I think all of us have spoken to blind people, and even when they develop blindness in infancy, they do not have a speech delay, leading to really no evidence that we know of that masks will delay children's speech. I would say that I would welcome new research on this topic, given the amount of children exposed. I would like our schools across the country to be on the lookout for any signs that speech is being delayed. But as I said, most of the task of developing your vowels and consonants occurs prior to kindergarten. As I close, I wanted to note that I am actively looking at how this is developing. Many other states in America and other counties in Maryland will be trying out going to school with masks optional. It's only August. Not a lot of school districts are open yet, but already just in the news and not in the scientific literature, we're seeing schools that kept masks optional start out in August trying to get their schools to stay open. Schools in Atlanta, Georgia, in Glasscock County, in Georgia, and in Arkansas have already run aground and had to go back and close their schools. And I've heard from so many residents, and I myself would love us to open our schools and retain in-person instruction. But as I said, I will be watching this. If we learn in September that the attempts that are being made in Maryland and around the country to make masks optional do not impair the risk of losing in-person instruction. If it works out great for our neighbors, I will quickly tell the school board what we've seen in our neighbors as they try this out. I think we should be open-minded about it and not dogmatic. And if you can preserve in-person instruction with masks optional, I will be the first to let you know, and then you can revisit the question. And we should be seeing how these attempts across the country work out over September and October. As I close, I'd like to remind everybody that the final decision about the school policy is not a decision made by the health officer. I'm here simply in the capacity as a medical expert and advisor. And like any doctor, I do not insist that you take the doctor's advice. Many other things for the school to consider, and I will respect your decision, whatever it is. I'd like to thank you for having me, and was very happy to share what I learned from the scientific literature with you tonight. Thank you.